Welcome everybody, my name's Craig Ritchie. I'm Professor of Psychiatry of Ageing, Honorary Professor of Psychiatry of Ageing at the University of Edinburgh and CEO and founder of a new company called Scottish Brain Sciences. And it's always an absolute delight to play any part in an Alzheimer Europe conference. And I'm particularly delighted to chair this session about brain health and prevention. And we've got 5 speakers this afternoon. Sophie Fuller from Brain Health Scotland, and then 4 students from the same research group at Maastricht University and the Alzheimer's Centre in Limburg. What we're going to do is each of the presenters is going to give you their presentation for sort of 10, 12 minutes or so, and at the end of each of the presentations we'll have 2 or 3 minutes for questions, answers and any comments. So I will hand over to Sophie, who I've worked together over the last few years at Brain Health Scotland, who's going to talk to you about an innovative project that's been done with school children and brain health. Sophie.
Hi, thanks so much, Craig, and thanks so much for having me. I'm Sophie Fraser. I'm Education Lead at Brain Health Scotland, and I'm here to tell you a little bit more about My Amazing Brain, STAR's school programme. So it's a little bit different from probably the presentations that you've seen before. These are very colourful and aimed towards kids, of course. The My Amazing Brain programme is a forward-thinking approach to prioritise brain health and to prevent dementia. It's an evidence-based campaign that empowers kids to look after their brain health. We teach kids to think that their brains are full of stars, and it's based on the fact that there are as many connections between brain cells as there are stars in the galaxy, which is an incredible thought. Children imagine that their brain are full of stars, and to keep their stars shining bright, they have to spend time with their friends. So this is all about socializing and learning new things. T is for tuck in, so that's all about nutritious food and drinking plenty of water. Active and healthy is all about exercise and getting your body moving and avoiding things like smoking and vaping. Rest and relax is all about sleep, getting good quality sleep, and we teach kids about the importance of relaxing and stress reduction. And finally, S is head safety. So we talk a lot to kids about obviously wearing a helmet, but also things like avoiding heading the ball and what to look out for concussion. This programme has been co-designed with parents, with educators, and with people with lived experience of dementia. And we offer learning opportunities in the classroom as well as at home. We hope with this programme that today's children will be the first to grow up knowing how to keep their brains healthy for life. So how it works. Teachers go to our website, which you should definitely check out. It's Brain Health Scotland /My Amazing Brain. They are asked their name, their email address, and the school that they work at, and how many kids that they're going to present to. They also are asked if they would like an in-person visit from one of our team, and also if they would like a brain health handbook for each of the children. Then they're taken to our website, which has a whole suite of free resources. We have lesson plans that range from 15 minutes, which is perfect for an assembly, 30 minutes, 90 minutes, and 6 one-hour block of lessons. We also have some brilliant extra resources. We have games, workbooks, colouring in sheets, and all our resources are available in Gaelic. A very important part of the programme is the Brain Health Handbook, which goes to each of the children. And this is to support the learning at home. So kids often don't have agency over what they eat and what time they go to bed. So the Brain Health Handbook is a really important document to support this learning at home. And the colouring sheets, quizzes and games and worksheets, we also allow for kids to take home and use at home. I'd like to do a quick introduction to the programme.
Hi, my name's Sky. I'm want to know more about how to keep our brain healthy.
Our brain is found inside our head and is made up of lots of connections between different brain cells.
There are actually as many connections in our brain as stars in the galaxy. Let's think about our brain as being full of stars.
Our brain controls our body moving. It sends messages to our legs to jump or to our arms to give a hug. It helps us understand things that we see, hear, taste, and feel.
And it's where we learn new things and our memories are stored. Our brain is in charge of all these special things, so it's really important that we look after it and keep our stars shining.
S-T-A-R-S, stars. It's a handy way to remember what we need to do to keep our brain healthy.
S is for spending time with friends and on hobbies.
T is for tucking into healthy food.
A is for being active and healthy.
R is for rest and relax.
And finally, S is for safety, keeping our head safe.
We're going to find out a bit more about the things we can do to keep our brain healthy, the stars way.
Your brain is amazing. Let's keep it that way.
So kids absolutely love these animations. They're fun, they're bright, they're colourful, and I love the Scottish accents myself. So the programme works so teachers can deliver the sessions in class as a learning block. Here are some kids enjoying the sessions, and they've done a whole block, and they've also used all of the extra resources. Teachers can also ask for an in-person visit from me. So this class had already done the block of lessons, and then I came in and did a really fun brain health activity with the kids. The teachers can also ask for a session such as a whole school assembly, and the resources are also perfect for after-school clubs such as the Scouts or something similar. So we've learned a lot in this past year, and the most important thing we've learned is that flexibility is really key. The demand on educators' time means that the more flexible we can be with the resources, the more that they'll be taken up. We've developed lessons to suit any timescale, so 15 minutes, and right through to 6 one-hour lessons. Collaborations. It's still our biggest challenge today, and always has been, reaching schools. It's very difficult to access schools, and the demand on educators and competing groups who all want to reach schools means that they're very difficult to communicate with. We learned from this and have partnered with lots of different community groups and community organisations, such as we created a bespoke set of activity cards for the Boys Brigade, and we had 5 activity cards that all the kids did different brain healthy activities, and this increases our reach and also creates relationships and routes into schools. So it's very similarly, marketing and communications, it's very difficult to reach schools. We found very quickly, day one, that you can't email a school. They get 500 emails a day, and unless you have a contact at a school, you just can't email a school. So we have developed brilliant relationships with teacher groups on social media, and we've partnered with organisations such as Twinkle, which is an education resource website, and we do things like social media live events, we do competitions, and we try and reach schools that way and incentivise sharing. And we also find that reaching schools through parents and family members, word of mouth, is really effective. So, so far, the resources have been used by 350 schools and 15,000 children. So that is just accessing from us directly. The collaborations that we've done have reached around 50,000 children. What we've learned from teachers is that the whole package is appealing. So kids are already learning about nutritious food and activity and how that's good for them. But combined with the lessons around sleep, around head safety, and around relaxation, creates a really appealing package. We've also found that the quality animations and graphics and the use of discussion, parents and teachers seem to really enjoy that. The bright animations, we found the kids have a really good recall of the program and of the lessons. So sleep, we didn't realize how much of a problem this was for educators and parents. At the moment, it's the biggest challenge facing teachers. And this element of the My Amazing Brain program has been extremely successful. We've heard so many stories and experienced in class that some kids, many kids, are only getting a few hours sleep a night. So this is something that we're really focusing on. We're doing specific sleep resources and competitions just to encourage this element of the program. The Brain Health Handbook is also very important to reinforce messages at home, and we found that kids who have done the program have actually influenced their parents and their family members for things like stopping smoking and stopping vaping. I think if you can get your kid to persuade, the way to access parents is to get their kid to tell them to stop smoking. So the most important bit, what have we learned from the kids? Kids really love brains. They think they're incredible, the look of them, the feel of them, and they love to know brain facts. So it's very handy. Education is key. I think it's sometimes very overwhelming seeing the challenges that kids face these days, and trying to teach kids about healthy, nutritious food when they haven't had breakfast and you don't know if they're going to have lunch is very difficult. But I think it's very powerful, and kids love to learn. So giving them the knowledge of the best choices to make is important. And every class is different, and every kid is different, which is why we have such flexible resources. I'm running out of time, so we've got great feedback. Really, really good feedback. And we've won an award. So our goals for 2024, there's too many really to fit on a slide, but we're working on a volunteer program just to expand our reach and to make sure that more kids are accessing these resources. We're working on accessibility so that every single child can learn how to keep their brain healthy. We're creating our resources in Braille and a book without words for people who learn better through visuals. And we're trying to reach rural communities. So we found that we've reached urban areas really well, but less so rural communities. And we're trying to reach 500 new schools by the end of next year. So if anyone wants to do a My Amazing Brain lesson, let me know. Thank you. Give us a follow and a like.
So thanks so much, Sophie. I just wanted to make sure there's a couple of minutes at the end for questions, because I'm sure there are some questions or comments from the audience. Yeah.
For sure. Or, well, would you like to do a program? Yeah, that would be fab. But yes, for sure.
We were very keen when we set this up not to commercialize it or to wrap it around with intellectual property. So all the materials and the videos and everything are free to use. So yeah, I mean, just access through Sophie, through Brain Health Scotland, and we can translate into other languages. So English should be okay. We should manage that one. It keeps the Brain Health Scotland logo in the corner of every slide, by the way. That's the only thing we have. Any other comments or? No? Okay, well, thank you very much, Sophie. That was brilliant. Thank you. So we're kind of staying in Scotland, but then moving over to Maastricht as well, because Lukas Duffner is going to talk to us about some work he's done in the Lothian Birth Cohort. So, Lukas, over to you.
Yeah, hello everybody. Thanks, Craig, for the introduction. So this project was somewhat unknowingly quite related to what you guys are doing, but it's more from an epidemiological perspective, actually. So yeah, my name is Lukas Duffner. I'm a fourth-year doctoral student at the Alzheimer Center Limburg. And yeah, before I start, I'd like to thank Alzheimer Europe for giving me the opportunity to present here today. And I'd also like to thank the Dutch Alzheimer's Association, not only for funding my stay here, but also for funding my 3-month research stay at the University of Edinburgh, which this project actually is a result of. So in the study, we examined associations between social and cognitive activity engagement throughout the life course and late life cognition in the Lothian Birth Cohort 1936. I have nothing to disclose. So as you may know, the engagement in mentally stimulating activities has been associated with slower cognitive decline, a lower risk for dementia, and to some extent also better neurostructural integrity. One of such mental stimulation factors is the engagement in social and cognitive leisure activities. And it is suggested that engagement in such activities may add to building up cognitive reserve in addition to other factors of mental stimulation, in particular education and occupational complexity. However, studies that examine leisure activity engagement in relation to late life cognition mainly focus on engagement in late life, so mainly measured at or after the age of 65. However, in order to take more of a life course approach, examining midlife and early life engagement in relation to late life cognitive outcomes can be very fruitful. As you may imagine, leisure activity engagement is also not really a static construct, but may actually kind of change throughout the life course based on or given the circumstances of a person. And there's to date no studies that actually look into how exactly this change may look like. Also, the interaction between those different sources of mental stimulation is not very well understood, in particular with regard to the primary sources of mental stimulation in that particular period in life. So, for instance, education in early life and occupational complexity in midlife. Also, the role of early life mental ability in all of this is not very clear. It is very possible that more intelligent children are actually put on somewhat on a path of success in which they would end up in longer and higher education, and then on average would end up in more mentally stimulating jobs, in addition to, maybe having a more or healthier lifestyle in general. So, in this current study, we first of all wanted to take a look at this change aspect of leisure activities. So we wanted to examine whether we could kind of cluster people into different groups of change throughout the life course, actually. And then as a next step, we wanted to assess whether being a member of or having a certain type of or trajectory of change actually predicts late life cognition, and whether this is independent of other risk factors for cognitive decline and dementia. And for this, we work with data of the Lothian Birth Cohort 1936, which is a group of people who were all born in exactly the same year, 1936. And they all completed a test of mental ability when they were 11 years old, so in 1947. And information about this test, the Murray House test number 12, is actually still available. And it was kind of rediscovered in the early 2000s, and this led to the establishment of the LBC. And the baseline measurement of 1,091 participants took place in the early 2000s, and this included measures of health, lifestyle, but also more neuropsychological assessment, actually an extensive neuropsychological test battery, and this has since been repeated across 6 waves. So leisure activities in the LBC are measured at age 70. So this is at study baseline, actually. At the same time, participants also provided information about their leisure activity engagement for when they were 18, 40, and 60 years old. So there was a retrospective questionnaire. And those are the activities that were included, and they were all rated on a 5-point Likert scale, ranging from never to every day or almost every day. And this information was available for approximately half of the sample. So we looked into late life cognition as our main outcome measure, and we used cognition data across 5 waves, so between the age of 70 and 83. And we included tests of memory, processing speed, and visual spatial ability. And we combined those, or we kind of operationalized those based on hierarchical latent growth curve modeling. So basically, this is a method that allows us to examine levels in cognition, but also change in cognition between age 70 and 83, depending on the covariates that we add. So as a first analysis step, we wanted to examine whether being more active at a specific point in life actually predicts late life cognition. So we included the leisure activity predictors at the respective point in life as separate variables. And in these analyses, we found that people who reported to be more active when they were 18, 40, and 60 years old actually predicted memory performance, so they had better memory performance at age 70, and this was independent of other risk factors for cognitive decline. However, only activity engagement at age 70 predicted subsequent change in cognition between age 70 and 83. In that those who reported to be more active at age 70 had a less steep decline in memory. And we actually found the same pattern for another aspect of cognition, for visual spatial ability. However, as you may imagine, so looking at those leisure activity measures as independent entities may not tell the entire story, because leisure activity engagement at one point in life may actually predict engagement at a later point. So it's from age 18 to 40, for instance, 40 to 60. And this change over time is actually more complex than we thought, as you can see in this very complicated Sankey plot of one of the activities playing board games. So this is really kind of all over the place. So in order to be able to still cluster people into different trajectory groups, we needed a method that could deal with this kind of complexity. And we found this in a method called growth mixture modeling. And without getting into too much detail here, this is a method that allows us to group people together while still leaving some room for error, for variation within those groups, because people might not follow exactly the same trajectory. This method also allows us to then use statistics to actually determine the best number of classes in addition to what, we think is actually theoretically sound. So following this measure, or this method, we came up with a solution that included 4 trajectory groups, so 4 mean trajectory groups of leisure activity engagement throughout the life course that you see here. So I will quickly walk you through this. So if you want to look at the red line, those are people who report relatively low leisure activity engagement throughout the entire life course. We call those stable low engagers. Then there's another group of people, the blue line. Those are people who report relatively low activity engagement in early life, but actually become increasingly more active throughout life. Then the purple line, so this is actually the biggest group. Those are people who have relatively high early life engagement, become slightly more active even in midlife, to then subsequently decline in activity engagement. And lastly, there's one group who actually stays active throughout the entire life course. So, as you can see, those groups differ in size, but they also differ in with regard to other aspects, for instance, sex, education, childhood IQ, general lifestyle, and APOE4 carriership. So this becomes important because at the next step, we actually want to examine whether being a member of one of those groups, or one of those 4 lines, actually predicts differences in level and change of cognition at age 70 and between age 70 and 83. So we included this group membership as main predictor in the subsequent regression analyses, and controlled for sex, childhood mental ability, years of education, a measure of occupational complexity, the Lifestyle for Brain Health Index, which is a summary score of several risk and protective factors for dementia that my colleague Colin will tell you all about in a second, and lastly, APOE4 carriership. So in those analyses, we found, we always used one of the groups, so the stable high group in green here, as a reference group, actually. And what we saw was that the people who remained relatively inactive throughout their life course actually had worse visual spatial ability scores at age 70 as compared to stable high engagers. And interestingly, this was independent of other risk factors for cognitive decline. However, we didn't find any other associations. Well, we actually did, but those were then explained by childhood mental ability, or differences in childhood mental ability and education, but actually not so much occupational complexity, which I think is an interesting finding on its own. So we also didn't find any associations between membership of one of the trajectory groups and subsequent change in cognition between age 70 and 83. So maybe this was a bit confusing, and I might have lost you somewhere along the way. This is quite complicated methodology, so I would like to summarize the main point, actually. So in looking at level of leisure activity engagement, we found that being more active at age 18, 40, and 60 was associated with better cognition at age 70. However, only levels of activity at age 70 predicted subsequent change. We then identified 4 plausible leisure activity trajectory groups, or life course trajectories, and we found that generally being and remaining more active was associated with one aspect of cognition, with visual spatial ability, but we also saw that more premorbid factors such as childhood mental ability still appear to play a role here. So overall, we believe that our findings may point into the direction that promoting mentally and socially active lifestyle throughout the entire life course should actually be promoted and may actually be beneficial. And in order to really understand how different risk factors at different points in life may interact and may accumulate, we have to take more of a life course perspective. So, yeah, this study has some limitations, which I would also quickly like to acknowledge if I still have the time. Yeah. Okay, so and this, the main shortcoming or potential limitation actually lies in the activity measure, because it was partly retrospective, and as you may imagine, this might have led to some degree of recall bias. Also, the included activities were quite restrictive, and they were also not available for the full sample, unfortunately. So what I would like to do is actually replicate those analyses. So this clustering of trajectories with different cohorts. So we are now in Maastricht, for instance, planning these analyses with the Maastricht Aging Study. But if you maybe have an idea of a cohort that includes prospective assessments of leisure activities for a relatively large sample, then yeah, I would be very happy to work with that and to discuss about that. For now, I'd like to thank my team from the Alzheimer Center Limburg, but also our collaborators from the University of Edinburgh and the Heriot Watt University. And I'd also like my team. It's a very great pleasure to work with you every day, and you're great. That's it. Yeah.
That was brilliant, Lukas. I'm sure we've got time for 1 or 2 questions. Congratulations, by the way. I mean, those were very complex statistical models, and I think you communicated them really well. So well done for that. Any questions for Lukas? I did have a question, but then you answered it in your final slide about collecting prospective data. Call me about the Prevent Dementia program, by the way. We might have some good data for you in that study. No other questions? Apart from me? Okay, fine. Okay, well, we'll hand the mic over then to Colin, who's going to talk to us about his study, again, from the same research group in Maastricht. And Lukas mentioned the LIBRA scale, about sort of its, this rating scale, if you like, that brings together many lifestyle factors, and you're going to talk about its value in the ELSA study. So over to you.
Exactly, thank you. So my name is Colin. I am also a third-year PhD student at the Research Line Risk and Prevention of the Alzheimer Centrum Limburg. And today I would like to have a chat about the LIBRA Index, because you might have heard the LIBRA Index today during the presentation of my colleague, perhaps yesterday, maybe at a different point in life. And we'll get you up to speed by telling a little bit about the history of this index, use cases of recent use cases, and how I recently updated the LIBRA Index as well. I don't have any conflicts of interest to declare for this presentation. So let me take you back first to 2013 when we conducted this study. And with the study, we really tried to identify and synthesize all of the knowledge out there with regards to risk and protective factors for dementia. We did so by combining a systematic review of the literature on one hand, together with the Delphi expert study on the other hand. And by combining these two types of data, we could come to a final list of risk and protective factors that could be suitable for dementia risk reduction. Well, shortly thereafter, we selected the most important ones. We rated them against each other. And as such, we came to our final model, which was then called Lifestyle for Brain Health Index, or LIBRA Index for short. And the original composition of the LIBRA Index is shown over here and was composed out of 12 different factors, all of which are modifiable. And as such, we say that it really is a risk reduction model rather than merely a risk prediction model, with a range going from -5.9 till 12.7, where the healthy factors within this index are weighted with a negative score, and the unhealthy factors weighted with a positive score, such that a higher LIBRA index indicates an unhealthy lifestyle. Well, this LIBRA index has been used very extensively in scientific literature, but also outside of scientific literature. So we have shown in a lot of studies that the higher LIBRA index is predictive of higher risk for dementia, cognitive decline, but also brain MRI abnormalities. And outside of these studies, we have also used the LIBRA index to develop a public awareness campaign on the one hand, and on the other hand, a brain coaching application. So it has had a lot of use cases already. However, over the last 10 years, there has, of course, been a lot of research investigating other potentially interesting factors as well. And the goal of my study the last 2 years was to identify and prioritize these factors. And I did so by going through a lot of literature, going through a lot of studies, and discussing them with a panel of 18 internationally renowned dementia experts. And the most important factors, according to them, which were lacking from the original LIBRA index, were hearing impairments, social contact, and sleep disturbances. So I added them to the LIBRA index. But I have to admit that this is an evolution rather than a revolution, considering that the total weight of these factors is about 14% of the total updated LIBRA index. And we created a new model here, but obviously we want to know whether this model is better than the previous model, preferably yes, of course. So we tested this model within the ELSA study, which is a long, ongoing study already running for more than 20 years in England. And it was characterized by 10 follow-up waves, and the 11th one coming pretty soon, set apart by 2 years. And at each of these waves, the participants had to fill in a very extensive self-questionnaire where they checked the behavior of the participant, health status, lifestyle factors, and life environment. And some of these waves were also supplemented with nurse visits to get more objective measures of health, such as cholesterol, weight, and blood pressure. For our analysis, we made use of wave 4 as our baseline wave, considering that it was the most complete wave with regards to the updated LIBRA index factors. And we used dementia as an outcome from wave 5 up till 9 as the outcome measure within our analysis, with a follow-up time of approximately a median of 10 years. And within this cohort, dementia status was ascertained by a means of a self or informant-reported physician diagnosis or a dementia screening tool. So there might still be an under-diagnosis of dementia within this population. And for our analysis of the association between the lifestyle on one hand and dementia on the other hand, we used Cox proportional hazard models. So there were some differences between the group of people that did develop dementia and the group of people who did not develop dementia within this data set. First of all, the people who did develop dementia were on average older, more frequently from the female sex. And the people who did not develop dementia, they had on average a higher educational attainment. In addition to this, we also saw that people who did develop dementia had a higher level of baseline LIBRA index scores and LIBRA version 2 index scores. And in addition to this, when we have a look at the individual factors included in the LIBRA index, we saw that the majority of the risk factors did indeed have a higher prevalence as well within the group of people that did develop dementia, with the exception of smoking and hypercholesterol. And this challenges our view on universal prevention also a little bit, considering that it could be the case that high cholesterol might be a risk factor during midlife, but a protective factor later in life. So this really calls for more personalized prevention. And in addition to this, the protective factors, which were statistically significantly different between both groups, were more prevalent among the people who did not develop dementia. And these are, once again, the two factors that were added to the updated LIBRA index. There was no significant difference between groups with regards to sleep disturbances. So over here, I would like to make the comparison on top between the original LIBRA index and then on the bottom, the updated LIBRA index. And a 1-point increase in original LIBRA index score was associated with a 13% increased risk of dementia. And when we do the same exercise with the updated LIBRA index, we saw that this was only 7%. So it might sound like this updated LIBRA index might actually be worse compared to the original LIBRA index, but this only has something to do with the theoretical range of values, because we updated the new LIBRA index with extra factors. The range really changed, and because of that, the effect of a 1-point increase is kind of diluted. So this is why we also had a look at tertiles of LIBRA index for both the updated and the original LIBRA index. And here we see that people that were in the highest tertile, so the 1/3 of people with the most unhealthy lifestyle, compared to the 1/3 of people with the best lifestyle, had a 171% increased risk for dementia based on the updated LIBRA index. So here it looks like the updated index is actually a little bit better. But to ultimately confirm which of these two versions is actually the best one, we also calculated the concordance indices. And it's a little bit difficult to see here for people in the back, so I'm trying to explain it a bit. But imagine a situation where we follow up two people, person A, person B. Person A has the higher LIBRA index, so the unhealthiest lifestyle, and this person did develop dementia after a follow-up time of 2 years. And then next to this, we have person B, who did have a follow-up time of 5 years and did not develop dementia. In this case, you would say that the LIBRA index did indeed correctly predict that person A would develop dementia earlier. So this is a concordant pair. And then situation B is a discordant pair, where the person who did have the highest LIBRA index did still end up developing dementia later in life. So this is a discordant pair, and the concordance index is nothing more than just the proportion of concordant pairs. So the discriminatory, whether the model can clearly discriminate between people who develop dementia and people who do not. And when we have a look at the ultimate concordance indices, there's not a major change, but it's a little bit higher. So what can we conclude from this study? Well, the predictive accuracy of the updated LIBRA index is at least as good as the original LIBRA index. It's not a major change, but hopefully a step in a good direction. So from an epidemiological perspective, it's not much better, but from a risk prediction perspective, it actually is, but because it added 3 factors which could act as entry points for dementia risk reduction. And when we have a specific look at the 3 components which were added, we could actually say that social contact and hearing impairment did add the most towards the prediction, and sleeping disturbances not so much. But this is clearly for this study sample, and it might be different in other cohorts. And what are some other things that we would like to do with this LIBRA index? Well, next we have to validate this index in other cohorts as well to see whether the updated model is indeed at least as good as the previous model, or perhaps even better. Additionally, we would also like to check whether there's any predictive validity of the LIBRA and updated LIBRA index for stroke, considering that both stroke and dementia probably have very similar underlying pathologies. And additionally, we would also like to check whether there's an interaction between lifestyle of people based on LIBRA index on one hand and genetic backgrounds on the other hand, because we know by now that risk factors do not affect everyone in the same way. And with that being said, I would really like to thank the rest of my team. By the end of this session, you're going to know all the names by heart. And I would also really like to thank all of the people that contributed towards the development of the updated LIBRA index, as well as my supervisory team that guides me through it, and Alzheimer Nederland for funding our stay over here. Thank you.
So thank you very much, Colin. Again, a brilliant scientific communication, difficult concepts statistically, but very well done sharing them with us. Yeah, good question.
Hi, Colin, could I ask you, I don't know if anybody else understood this, and probably they did, and I just hadn't really understood fully. But in terms of...
So apparently we've got one microphone and I have to share it with you.
Sorry.
Please give it back again. Okay.
Of course, no problem. Thank you so much. Hi, Colin. Sorry, I hope you can hear me better now. I was particularly intrigued by one of the results that you reported, and that related to the association with no dementia, where you looked at smoking and high cholesterol in later life, at a later life point. And I'm just wondering if you have any notion of what is mediating those results. And I'm wondering whether it's something to do with higher levels of sociability, because we tend to think of smokers as being more sociable. And is that, in fact, what's causing the protective effect of smoking and high cholesterol, which may well both be related anyway?
Yeah, that's really the problem with these indices as well. Actually, in reality, all of these components are in some way related to each other, and your hypothesis might well be true. Might also be the case that people who are starting to develop dementia are more likely to quit smoking because they don't have any interest in it anymore. So it could actually go both ways. And we do have projects that are looking as well into these more complex interactions, but it's indeed a little bit difficult to see them separately from each other. Yeah.
Thank you. Okay, yes, another question.
When you were doing the update with the focus group and the literature review between LIBRA 1 and 2, did you consider including the elements that we heard about this morning, like air pollution, noise pollution?
We certainly have considered it, and we also, that they often told us to include it as well. But the focus of the LIBRA index is really on modifiable factors which you can modify at the individual level, like blood pressure, because that's something that you can influence. Air pollution can also be influenced, obviously, but it's very difficult to do that on the individual level. I can difficult say to everybody from my region of Belgium, oh, go live at the sea, because the air is more healthy over there. But yeah, because of the scope of the LIBRA index, we did decide not to include them.
Okay, thanks very much. I think we should probably pass on now to Lotte. Thanks very much, Colin. So welcome up Lotte Truin, also from the same research group, who's presenting a paper on knowledge, needs and preferences of persons with subjective cognitive decline, or MCI, and their healthcare providers on dementia risk reduction. Thank you.
Yes, thank you. Good afternoon, everyone. My name is Lotte Truin. I'm also a PhD student at the Alzheimer Center in Limburg at the Risk and Prevention line. And today I will tell you something about our study on the knowledge, needs and preferences of people with subjective cognitive decline or mild cognitive impairment and their healthcare providers on dementia risk reduction. So I think that we're all well aware that dementia is an incurable disease at the moment, and therefore a lot of effort is put into the risk reduction of dementia through lifestyle modifications. We also know that people who have subjective cognitive decline or mild cognitive impairment are at increased risk of developing dementia. So this group of people can really benefit of efforts made for risk reduction of dementia. So really the secondary prevention of dementia. What we know from clinical practice from our own memory clinic in Maastricht, for example, is that when patients with subjective cognitive decline or mild cognitive impairment come to the memory clinic for their psychosocial evaluation, and they get, for example, a diagnosis of MCI, or they get told that they have subjective memory complaints, they ask their healthcare providers, okay, so what can I do myself to keep my brain as healthy as possible, or to decrease my risk on developing dementia as much as possible? And we also know that the healthcare professionals are sometimes kind of left empty-handed. So they don't really have time in their consultations to talk about risk reduction of dementia through lifestyle that much, or they don't have any materials to give to their patients. And with this study, we try to fill that gap and to develop these kind of educational materials which will give the patients from the memory clinic information about risk reduction of dementia through lifestyle modifications. And to do so, of course, you need a good needs assessment first. So really to find out what the people who will use the educational material need in this material. And therefore we had two aims in this study. We tried to assess the current knowledge on dementia risk reduction and to investigate the needs and preferences on dementia risk reduction, but also on the educational material in people with STD or MCI and their healthcare professionals, and then specifically for the Dutch memory clinics. And for this we used a mixed methods approach. So we combined an online survey together with in-depth interviews. Our online survey really tried to assess the awareness of risk reduction of dementia and touched upon a little bit of what the preferences and needs were for this educational material. But in the interviews, we tried to go more in depth with participants on what they feel like the educational material should look like, what kind of information it should entail. So we used this mixed methods approach. Our participants were both people with STD or MCI and healthcare professionals from the memory clinics. And the other only inclusion criteria was really that they had an internet connection, because our survey was online and most of the interviews were also conducted online. And we tried to keep our inclusion as broad as possible so that we can get as many opinions as possible on this educational material. Moving on to some of the preliminary results of this study. As you can see here, we were very happy to include quite a lot of participants in this study. So we had 65 healthcare professionals from the memory clinic and more than 1,100 patients with STD or MCI. And I think what is important to note here is that for the healthcare professionals, most of the healthcare professionals were female. We really had a range of different occupations at the memory clinic. So we included physicians, psychologists, but also nurses and other staff members from the memory clinic. And also the years of work experience varied a lot. So we included healthcare professionals that had a work experience of less than a year, but also who already worked there for 20 years. For the patients, although we had a large age range, so from 20 to 90 years old, it's important to note that the mean age was a little bit older, so 63.8 years. Also here, most of the patients were female, and more than half of the patients were highly educated. When we asked patients and healthcare professionals if they thought they could do something about their risk of dementia, of developing dementia, almost 40% of patients said that they didn't think they could do anything to reduce their risk of dementia. Luckily, the healthcare professionals were more up to date, so 90% said that they could do something about their risk of dementia. When we asked the patients if they would like to get some more information on risk reduction of dementia, and 98% of the participants said that they would like this. And we also asked them in what way they would like to receive this kind of information. And almost 80% said that they would like to receive this information through the internet, or in combination, so some paper materials as well as, for example, a website or an app. We also asked healthcare professionals if they talked about dementia risk reduction through lifestyle modifications in their daily practice, and 95% of the patients said that they talked about this topic in any form. Lastly, we asked in the survey to both patients and healthcare professionals if they would use an online tool on brain health and lifestyle. And both luckily said that the majority of the participants both said that they would like to use such a tool. So 98% of the patients was interested in this kind of tool, and almost 90% of the healthcare professionals. Moving on to some preliminary findings from our in-depth interviews. These findings are really preliminary. We're still working on the main analysis. But we, in total, did 23 interviews, 14 with people who had either SCD or MCI, and 9 with healthcare professionals. And I can share the 3 main topics we found up until now about the educational material. So this material should be easy to use, but still visually appealing material. So you can also see it in the quote that I put here on this slide. Some participants said that they always say to keep things simple, and also in this instance, with this kind of educational material, keep it as simple as possible. But also, keep it simple, but we find also that people really want in-depth information, but in an understandable form. So they want to hear something new, but it shouldn't be in children's language, which you can also see here in the quotes, but it should also not be really scientific. And if we use scientific words, that we should really elaborate on it and explain it. Lastly, people found it a great addition if the material could be in any form personalized, and maybe some type of coaching could be there. To conclude, we saw that almost 40% of people with SCD or MCI were unaware, and 98% of people with SCD MCI expressed a need for more information on dementia risk reduction. Almost 98% of people with SCD or MCI and 90% of healthcare professionals would consider using an online tool meant for brain health and lifestyle. The most important features for this tool should be user-friendliness, understandable but in-depth information, and there should be some kind of personalized form. So we actually started developing this educational material, and we ended up with an online website, a conversation starter on paper, and some posters. And of course, this was on dementia risk reduction and specifically designed for the Dutch memory clinics. What we kept in mind while developing this educational material were these 4 points. So we wanted really to show people who use this tool or use this material what their room for improvement in their lifestyle was, to inform them on the relationship between lifestyle and the brain health, and really to entice people to make brain healthy lifestyle choices. Besides this, we really wanted the material to be a conversation starter for in the memory clinics, so conversation starter for patients and healthcare professionals to talk about lifestyle and brain health. And I'm very happy to share first images of the material. This is the online website. It's called Breinzorg. It's in Dutch because, of course, it was designed for the Dutch memory clinics, but literally translated, Breinzorg is brain care. People can fill in a test on their lifestyle, and they will get personalized recommendations on which lifestyle factors they can work. And these are the kind of factors that we included, so only modifiable factors, of course. This is also part of the conversation starter, so the paper material that we have developed. So the healthcare professionals can use this in their clinical practice to start a conversation about lifestyle and brain health. And with that, I would like to conclude my presentation, but first I want to thank all my colleagues. And I also would like to thank all my co-authors of this study, and a special thanks to Alzheimer Netherlands for the travel grant.
So, thank you very much, Lotte. Any questions, comments, reflections? Yeah. So I've got to come right to the back of the room. No, I've got to, so people can hear us online. You could have come to me.
Thanks, Lotte. That was a really nice talk. So you mentioned there that the materials you've designed are for Dutch memory clinics. But as we all know, there are a big population of people with undiagnosed SCD and MCI in the community, and a very large population of people who are at risk of those conditions. How would you see adapting those materials to more community-based purposes?
Do you mean then intercultural, or in what form do you mean exactly?
Sorry. I mean, do you think, could this type of material be made available for a broader audience, basically?
For a broader audience. Yeah. Well, actually, this was really tailored for people with SCD or MCI, because we also, the basis of the kind of modules that were included, so the lifestyle factors, were really, we found them in the literature through a meta-analysis and a systematic review. So it's really tailored to people with SCD and MCI, but I think there's a lot of overlap, for example, also to healthy people without memory complaints. So of course I think if you adapt it well, you can also use it in different populations, but really think that needs to be taken into account that these are the risk factors for people with SCD and MCI. But yeah, I think you can adapt it, of course. Yeah.
Brilliant. I've just got one quick question. I mean, the data was amazing, huge survey of both clinicians, practitioners, as well as the patients with SCD and MCI. But of course, one of your exclusion criteria or inclusion criteria was access to the internet. And we know that, certainly in the work we've done in Scotland, that access to the internet can be associated with socioeconomic deprivation, which is associated with higher levels of these risk factors. Are there any thoughts or moves in place to think about how we can make this available to people who don't have easy access to the internet?
Yes, thank you for your question. That's definitely something that we thought about also. Of course, we have the highly educated people included in this study mostly. This is also why we made some paper materials, so that hopefully it's a little bit better accessible for people who are not as good, for example, with the internet. And I think if we want to reach the more difficult reachable population, we should look at maybe key figures in the society. So for example, maybe also work together. This is now for the memory clinic, but maybe also work together with, for example, the family physician, something like that. Yeah.
Okay, thank you very much. Are there any other questions? Okay, thank you very much, Lotte. So our final presentation this afternoon is the fourth and final PhD student from the Maastricht group. So Jens, the floor is yours.
No. Thank you, Craig, for the introduction. My name is indeed Jens Soeterboek. I'm a doctoral student from Maastricht University and also the Alzheimer Center in Limburg. And my project is about the association of ambient air pollution with cognitive functioning and structural brain damage, with data from the Maastricht Study. So I have nothing to disclose, and I'll give you some background to this project first. So dementia prevention is one of the biggest challenges to the aging society, but most prevention research has focused on individual risk factors. But there's also something we all share, which is the environment. So herefore we can look at the images on the right side of the slide. We have two different scenarios. We have an older couple walking in a park, and we also have someone working out on what seems to be a very busy street with cars and not a lot of green. Those are different scenarios, but it's both physical activity, so you could argue which of those scenarios is positive and which one is negatively impacting a lifestyle, and you can see what the role of the environment could be for a healthy lifestyle and for brain functioning. But there's one factor that has been named quite a bit today and also yesterday, which is air pollution. So yeah, we'll get right into it. There has been lots of reports of air pollution in different scenarios. So I have some examples. Costs of death increasing through air pollution, but also overall organ damage through air pollution. We have reductions in intelligence through air pollution, but also, as we are all here today, for likely risk for dementia increase. And officially in 2020, the Lancet Commission report in 2020 included air pollution as an official risk factor in later life, having potentially more weights than other risk factors that are known, such as hypertension and diabetes. So for this project, we were looking at different research questions. First of all, whether there's an association with exposure to ambient air pollution, with cognitive functioning, but also markers of brain damage. And then also, if there is an association with the outcomes and air pollution, if we control for socioeconomic status, but also individual lifestyle factors. So for data, we use data from the Maastricht Study, which is a cohort study. And for this specific study, the data was used in a cross-sectional manner and is described with an extensive phenotyping approach. There is also an oversampling of type 2 diabetes in the study, which has to be named. But the overall sample size was 7,689 participants. And the age range is 40 to 75 years of age. They're all from the region of Limburg, as indicated by the star on the map, which is the most southern region of the Netherlands. The inclusion criteria for this study are, of course, availability of air pollution data. Then we also needed MRI data and cognitive functioning, cognitive testing. But then also the LIBRA score had to be able to be made. So this was also an inclusion criteria, and by now you probably already know what the LIBRA score is, but yeah, higher score indicates greater risk. So these data was matched with data from the Geoscience and Health Cohort Consortium. So therefore, the Geoscience and Health Consortium has data that is modeled on a very high spatial resolution, 25 by 25 meters. We chose for particulate matter that is smaller than 2.5 micrometers, smaller than 10 micrometers, nitrogen dioxide and soot, so mostly traffic related and also exhaust fumes from companies and burning of wood. And those could be modeled to or matched to address level data from the Maastricht Study participants. As a size comparison, you can see here a strand of hair with particulate matter as a size comparison. The hypothesis would be that the smaller the particles, the further they can reach into the body. And so for this study, we used the 4 air pollutants as predictors. They were available as annual averages. And then as stepwise inclusion in the regression models, we used the following covariates: age, sex, diabetes status due to the oversampling in the Maastricht study, but then also the LIBRA score and socioeconomic status as a compound score made out of education, occupation, and income. So the outcome variables we used for cognitive functioning was the domain scores, executive functioning and attention, information processing speed, and memory, but then also an overall cognitive functioning score. For markers of brain damage of the MRI, we used volumetric measurements for gray matter, white matter hyperintensities, and cerebral spinal fluid volumes. But then also we looked at the presence of cerebral small vessel disease. The results were in the beginning a little bit disheartening, but we found no... Is it coming? Yeah. We found no significant association with air pollution exposure, any of the pollutants in any of the models with cognitive functioning. And we also didn't find any significant associations with white matter volume, white matter hyperintensity volumes, presence of cerebral small vessel disease. But what should be named is that these were all made by linear regression models. And previous research has also suggested that there might be nonlinear associations for these specific pollutants, especially particulate matter. So we also looked at the marginal means plots, and we indeed found that for gray matter volumes and cerebral spinal fluid volumes, there were nonlinear associations observed only for particulate matter, so smaller than 2.5 micrometers, but also smaller than 10 micrometers. And therefore we employed restricted cubic splines regressions, which will now seem a little bit more technical, but the main focus will be on the graphs. So if we start looking at the top left graph, First of all, we can start at this point. The point of the restricted cubic splines is to make this a little bit more visual and make it more simple, but the concept is quite difficult, so let's look at the graph like this. The arrow points at the lower to mid-range exposure in this specific sample. So you can see the graph from the minimum to the maximum exposure in this specific group. And lower to mid-range exposure and an increase in there was associated with higher gray matter volumes, which is not what you would expect. But then this association turns around after the peak, and then you can see that higher air pollution exposure in the mid to high range is associated with lower gray matter volumes. So this same but then turnaround association was observed for cerebral spinal fluid volumes. So first, also in the low to mid-range, it was associated with lower cerebral spinal fluid volumes, and then it was associated with higher cerebral spinal fluid volumes. I don't know if you remember the presentation in this morning, the plenary session, higher air pollution was associated with brain shrinkage. So this is not a prospective study, but this kind of effect was also a little bit observed. But we were wondering why these two directionalities were there, because this was not what we were expecting. So for sensitivity analyses, we added a degree of urbanization to the model to explore these directionalities. And urbanization is at the home address of the participant in a radius of 1 kilometer, the address density that is observed there. So after adding this, the first splines, so like the increase that disappeared, was no longer significant. However, the mid to high range exposure that was significant still remained. This was not the case for particulate matter smaller than 2.5 micrometers on gray matter volumes, but for the rest, this effect appeared. We also did interaction analyses with sex, age, type 2 diabetes status. To be fair, also included socioeconomic status for an interaction, because that was kind of what we expected, that this would play a role in the effect, but there was no significant interaction to be observed. So to summarize, higher exposure in the mid to high range of air pollution exposure for especially particulate matter was associated with low gray matter volumes and higher cerebral spinal fluid volumes. We found no significant associations with cognitive functioning, any of the domain scores, or overall cognitive functioning. However, this has also been observed in another Dutch study investigating air pollution. This was based on cognitive decline, but they also did not find any cognitive significant association with cognitive decline in the Rotterdam study, where the average exposure was even higher than in the Maastricht study. To clarify this even more, we have a heat map here of the whole of the Netherlands on the left side. You can see in the north that the area is much cleaner health. You can see it at the green area, but the Maastricht study is right down in the south, so it's more darker orange-red. And on the right side, this is the inclusion area of all participants, where they're from. So you can see the Maastricht is deep red, but the rest of the inclusion area is also not that great. So if we zoom into this a little bit higher, you see that the highly urbanized regions are more red. Especially in this region, this is something different, because in studies from Northern America, for example, it was the lower socioeconomic status areas that were exposed to higher air pollution, but this was not possible to observe in this study region, because it could be because Maastricht is kind of in a valley, so we get the air pollution from Germany but also from Belgium, and it gets stuck in the middle. So this could be why. Yeah, for personal motivation, this is where I live, so that's kind of why it's interesting. And I'm also a little bit sensitive to air changes, so that's good for me. But this study has like a lot of strength, because it's a population-based design with a large sample size, and the midlife age range from 40 to 75, where targeting dementia risk reduction isn't very effective, and the extensive phenotyping approach. So we could get all the individual risk factors. We had MRI sampling, and we also had cognition testing, and this would match with high spatial resolution with the Geoscience and Health Cohort Consortium data. However, there were also limitations. There was, as I just mentioned, limited exposure variation. This could be something that is just typical for this region, but that's what we observed. And we also could not control for the individual mobility. We had yearly averages, but people don't usually spend all their time at home, so they also go to work. They do different things. We could not control for that. And we cannot make any causal inferences based on this cross-sectional data. But there might also have been selection bias through inclusion of MRI data. I checked that the participant we excluded, for which we did not have MRI data, and they had on average higher air pollution values than the people we included. So what are the implications here for? It might be that people, independent of socioeconomic status and lifestyle factors, might be more vulnerable if they're living in high air pollution regions, might be. And that prevention is only possible for factors we can influence. But the air pollution that we experience can be influenced. The World Health Organization is permanently bringing down the averages that we need to achieve. But there needs to be more evidence and more awareness spread for governments and policy-making institutions to act on this. Because we cannot do this on an individual basis. This has to be tackled from way above. So the future research should be on more exposure-diverse samples, potentially also including ultrafine particles, because this was not possible in this sample. But also different regions, just geographically different, not including potentially only valleys where things get stuck, but yeah, also look at different socioeconomic status variables. There might be other factors that distort the results that fall under a socioeconomic status spectrum. So yeah, if there's any ideas on why these associations occur, or like what else could be looked at, feel free to approach me afterwards, or yeah, connect with me later on if there's other studies that are based on this. You might not want to see this again, but it's here. I also want to thank my team for being here and supporting me, as well as my co-authors, Alzheimer Nederland for the study grant, and Alzheimer Europe for having me. Thank you very much.
Thank you very much, Jens. I'm beginning to wonder where the PhD candidates that you have aren't on the stage. Are they here as well, the whole group here? Anyway, yeah, brilliant, absolutely. And you're presenting later? Yesterday, very good, okay. Congratulations on such a group, wonderful for the supervisors. Any questions for Jens? Yeah, got a hand straight away.
Thank you so much. That was so interesting. Now, this may have been touched on already this morning. Unfortunately, I wasn't able to be at that session. But I'm just wondering whether you have any intention, or if your research group has any intention of taking this in situ. Thinking about a study that I saw a presentation on at a European Parliament lunch debate in Brussels earlier this year. And they had people in a chamber where they were pouring in pollution, and they were having them cycle, and they looked at changes at a cellular level when exposed to pollution, and the implications of that for brain and overall body inflammation. So I'm just interested to see what you think.
Yeah, thank you very much for the question. That is indeed a very interesting study. Yeah, I saw that as well in the presentation. Yeah, that's not really my area of research. It's more epidemiological based, but that is definitely needed to see also like where the biomarkers are affected and what happens on a cellular level. I agree with that. That's very important, but that's not what I say. But thank you.
So, is there any other questions for Jens in the last couple of minutes? I've got one really important question. That photograph of the person running down the street. Was that you?
No.
No, okay. I was trying to work it out. I was looking at it closely, and then I saw you with the mask at the end and thought, nah, he'd be running with a mask, so it wasn't you. It wasn't you. Oh, there is one more question, sorry. Okay. Stop me telling bad jokes. Good for you.
Yeah, just a short one. Thank you for the brilliant presentation. I noticed that you said you weren't able to control for mobility and how people spend their days, but were you by any chance able to assess how long people had been living in their respective place of residence? Because I've heard from studies investigating the effect of noise that this only tends to become apparent after people have had this level of exposure for quite some time.
Yeah, thank you for that question. That is indeed something I was also trying to find. But we had the baseline addresses, and we did not have the data available for if they moved and where they moved. Yeah, that is unfortunately a shame, yeah.
Oh, Mary, I was going to try and get you away early for your coffee, but you've drawn me back again.
2 seconds. Sorry, just something just suddenly flashed back to me from a geography lesson in about 1984. So I lived in a town that was very industrial in Scotland, and we were looking at air pollution levels in the town. And what we noticed was that geographically they were differently distributed because the houses tended to be built in different geographical distributions. So the more affluent areas in this town, there weren't many, but the more affluent ones were placed away from the factories, the steel factories, but in a way to make sure that the wind didn't blow the pollution towards there. So I'm wondering whether you control for exact areas within a town or city, and whether you think that's important.
Thank you very much. That is indeed also an idea I was just wondering about, because we controlled for urbanization, so the degree on which the address density is made. But we did not control for a specific, so for example, you mean maybe a socioeconomic status of areas of the city, something like that?
Essentially, yes, because I think the poorer areas, there seemed to be no protection from the pollution, because it would be the wind would usually go in the direction of those areas.
That is actually something I'm planning to look into in the future. Just broadening the spectrum of socioeconomic status, because based on research, I was also expecting that people that live closer to factories or live in areas of cities that are closer to highways, or, you know, like those kinds of areas that are usually of lower socioeconomic status and affluency, that they would be more exposed to air pollution. But what we found was that the center of the city, which is usually where the most expensive houses are and the higher socioeconomic status can be found, that there the air pollution was the highest. Not to say that the air pollution was low in the other areas, but yeah, the highest was found indeed in the center, which is not what we expected. So it's like, there might be something specific to this research.
Okay. And also different sorts of pollution as well, because in the city centres, where they're more affluent, it's going to be traffic-generated pollution generally, not factories. But
That is also true. Yeah.
Thank you so much.
Thank you.
Thank you so much. And I'm not going to summarize all those presentations before we end. I'm just going to leave on an optimistic note. I think you'll all agree that the quality of early career research presentations you've heard today is second to none. The future's in good hands, so congratulations to all of you. And very good hands for the children who are going to have healthy brains and become like these four one day because of their healthy brains, at least in Scotland, and maybe in England as well. So thank you also for the audience participation. Brilliant session. Thank you, everybody.